Hey guys, Sue Morris here again for the Provincial New Brunswick Critical Care Nursing Program. And I'm going to discuss this as a very quick overview of vascular disease and how it relates to critical care. So please know that this is not a comprehensive overview of vascular disease by any stretch of the imagination. So when we think about vascular emergencies, we think of limb ischemia. So whether somebody has had an embolic event or maybe they've developed compartment syndrome related to internal bleeding. We're also going to look at some of the vascular abnormalities that can cause a really acute problem, such as a thoracic or abdominal aortic aneurysm rupture, or we can also have patients who present with type A and type B aortic dissection. So those are going to be the three vascular emergencies that we're going to explore today. So in case-based format, we'll look at Mr. Jack Daniels. He's a post-op cardiac catheterization patient. They used his right femoral artery. Obviously, he failed his Allen's test, and so he is not a radial approach. So they approached his right femoral. His vital signs got a heart rate of 51, a blood pressure of 167 on 92. His temp is 37.3, respiratory rate is 17, and he's on 2 liters with a SAT of 98%. One would question, does he really need that oxygen? And I would suspect not. So when we talk about limb assessment and in determining the integrity of a limb, we often think of the 5 Ps. Some people say there are 6 Ps. So pain, pallor, pulse, paralysis, paresthesia. So pain that's out of proportion to what's happening with the patient. So ischemic pain, ischemic leg pain is very painful. So pain, pallor, blue is, I always say blue is cool, but white's not right. And compare your left and your right, compare the extremities. So pain, pallor, pulse. Do you have distal pulses? Paralysis. Paralysis is a really late sign of poor limb integrity. And so by the time you get to that, you really have not done a very good job of managing this patient's limb. And then paresthesia. Paresthesia is that tingling or numbness that some patients get. Our patients will always complain of some type of paresthesia when we have a radial approach with a radial bracelet. But again, assess and compare your left and your right. So pain, pallor, pulse, paralysis, paresthesia. And then the 6th one is called poikilothermia. Don't ask me how to spell it. But basically it means that a dead limb takes on the temperature of its environment. So at one time, medical resident, surgery resident, I guess he was really confused and told me there was nothing wrong with the leg when I asked him to come and assess it. And I said to him, oh no, this patient needs to go back to the OR for an embolectomy. And he kind of looked at me and he said, but the leg's nice and warm. And I chuckled and said, that's because I'm a good nurse and I went and got a nice warm blanket and wrapped the patient's leg up for comfort. Poikilothermia takes on the temperature of its environment. So the resident kind of looked at me, and once we left the blanket off for a few minutes, he could see how white the leg was, how patient had lost the pulses, and the leg really started to get cool. So some people will talk about poikilothermia. So back to Mr. Daniels, he rings his bell and says, "Oh no, nurse, my leg feels all weird and wet." And when you assess his femoral cannulation site, this is what you see. So obviously he's got an arterial bleed. What is happening here? So you're going to apply direct pressure to this. There is never a period where you put your bare hands in somebody's groin who's bleeding like that. Please protect yourself. Grab a pair of gloves. Even if you don't have sterile gauze, protect yourself with gloves. And you're not going to put pressure on with the palms of your hand. You're going to use 2, max 3 fingers. And you are going to have 1 finger on the insertion site and 1 finger above it, because when you think about this patient's femoral artery, so here's the femoral artery, up here is my patient's head, and down here are his feet. That's supposed to be a foot, sorry. So when they cannulate the skin is up here. We'll say it's just kind of a bumpy looking skin. When they cannulate the skin, they go in at an angle like this. And so this is your catheter that's going into the patient here. So when you apply pressure, you are going to put it here and here so that you are compressing the arterial site and also the skin site. So I like to use 3 fingers. People are going to tell you different periods of time. The evidence suggests that we should apply direct pressure without release for 20 minutes. And if you're the kind of nurse that likes to peek, then you have to reset your 20 minutes. So if you take a peek and say, "Oh, is it still bleeding?" Reset your 20 minutes. So remember that if you are holding this man's groin, there is a fine line between stopping the hemorrhage and completely occluding that femoral artery. And so I will often call out to my colleague in a very calm voice, because I don't want to scare the patient. And I'll say, "Hey, Sally, can I get a hand in here?" And so Sally will come in, and if she sees me applying pressure in the cannulation site, then she should automatically come over, remove the bedclothes from both of the patient's feet, and allow us to both assess what the legs look like, what the feet look like. And then she is going to assess a pedal pulse in the foot of the leg that is affected. And I should have enough pressure to stop bleeding, but I should continue to have a pulse. Now, remember, if the patient didn't have a pulse before he went to the cath lab, he's not going to have one now. And so you may need to get a Doppler. So you've applied pressure for 20 minutes, and then you will assess this patient's groin again. So put gloves on, apply pressure. When we think about Mr. Jack Daniels, I'm just going to go back for a second. I want you to look at all of his vital signs here. And is there one that you're concerned about with regard to his bleeding? And it would be his blood pressure of 167 on 92. As I am applying pressure, I would get one of my colleagues to call the physician, because I want to give him something for that hypertension to bring the blood pressure down, so that I am not as at big a risk for bleeding. We know that the higher pressure a vessel is under, the more likely it will be to bleed. So there's a fine line between enough blood pressure to perfuse our head, heart, and kidneys, and one that doesn't make us bleed too much. So I suspect that this patient would receive an antihypertensive while I am applying pressure. Sometimes we use nitropase. Sometimes we say, what did we have on hold for the cardiac cath? Maybe his ACE inhibitor can be restarted, a beta blocker, although he looks pretty well beta blocked with a heart rate of 51. So yeah, think about how high your blood pressure is in this example. Let's say that Mr. Daniels did not bleed out. But when you go in to assess his insertion site, you see this large area of discoloration. And when you palpate the insertion site, you feel a large hematoma. I'll be honest with you, I would actually like a patient to bleed out more than bleed in. So both scenarios have equal concern, but this patient is more likely to develop a compartment syndrome. I do not treat them any differently. Both require direct application of pressure for a minimum of 20 minutes. But this patient I have to pay special attention to for the next 24 to 48 hours to ensure he does not develop compartment syndrome. And so application of pressure is the same. 3 fingers, 1 at the insertion site and usually 2 above. And again, I get my colleague to assess my leg to make sure that I can see both of my feet, and he is assessing whether there is flow distally with either a Doppler or palpating the pedal pulses. So compartment syndrome, I've had a few patients who have developed compartment syndrome, and this patient can develop limb ischemia very quickly, and you really need to be on top of this because this is a medical/surgical emergency. And so the patient may need a fasciotomy to release the pressure and allow blood flow to be resumed to the distal foot. So it can be a really big deal, and you as a nurse need to pay attention to it. Much more common when the patient bleeds inward and develops that big femoral hematoma. So keep a really close eye on it. Sometimes they even have to do actually more commonly, they need to do upper leg fasciotomies, not lower leg. Okay, so we have a new patient here. This is Joe Smirnoff, and he's admitted to the medical floor with a diagnosis of exacerbation of COPD. He's got a heart rate of 88. It's sinus rhythm with some PVCs. And then he also has some periods of AFib. His blood pressure is 152 on 81. His temp is 37.3. Respiratory rate is 29, and his SATs are 94%. But he is on high flow oxygen through an OptiFlow. FiO2 or percentage of oxygen is 35%. So he was given 20 milligrams of Lasix, and he was started on an antibiotic because the doc wasn't sure whether he has superimposed pneumonia on top of his heart failure and his COPD. So this poor guy has COPD, 2-pack per day smoker for 25 years. He has long-standing hypertension. He has stable angina, And remember when we talked about acute coronary syndromes, we said that unstable angina, non-STEMI and STEMI were the acute coronary syndromes. But we also said, keep in mind when patients get admitted with stable angina, sometimes that supply-demand imbalance will come into play because we're stressing the patient or the illness is stressing the patient. So I think about his stable angina, and I always keep that in the back of my mind. He has a 4-centimeter abdominal aortic aneurysm. He has osteoarthritis and gout. So it's got pretty big past medical history. Oh no. So while you're completing your admission, you walk into his room because you're a conscientious nurse and you're going to get that best possible medication history. And the patient is pulseless in the bed. So what's a nurse to do? She's going to call a code blue because there is no pulse. The team arrive and Joe is connected to the defibrillator. And this is his rhythm. So he has a rhythm, but no pulse. PEA, pulseless electrical activity. And as soon as I hear PEA, I think H's and T's. Two most common reasons for PEA and asystole are hypovolemia and hypoxia. So this gentleman was laying in bed talking to me and was on some Optiflow. I'm wondering, could it be hypoxia? I also wonder, could it be hypovolemia? I wonder, well, why would it be hypovolemic? And when we go back here and look at his past medical history, he does have a 4-centimeter abdominal aortic aneurysm. And so we investigate the H's and T's. There could be a number of them. Could be coronary thrombosis, pulmonary thrombosis. And when we have a patient we're not really sure what's happening, sometimes a bedside ultrasound during the code blue or POCUS, point of care ultrasound, is very beneficial. And so if you had a big pulmonary embolism that was obstructing flow from the right ventricle, then when you put the POCUS wand on the patient, the physician would see a dilated right ventricle. But they don't see that in Joe's case. What they see are two ventricular walls that are touching each other when it contracts or when it compression is offered. And that tells us he is hypovolemic. They actually can do a quick abdominal ultrasound and they see that Joe has a belly full of blood. So they're strongly suspecting now that he has a ruptured abdominal aortic aneurysm. And so when we talk about aneurysms, we can have abdominal or we can have thoracic. And so here would be a picture of what Joe's look like. Maybe not this big, but it did rupture. It's an outpoaching of all 3 layers of the arterial wall. So the intima, the media, and the adventitia. So it can be saccular in nature, so like this one. It can be fusiform where one side is outpoaching. But oftentimes people get confused between what is a dissection and what is an aneurysm. The big difference is an aneurysm involves all 3 layers of the arterial wall. and it's an outpoaching. Whereas a dissection, blood gets between the intima and the media because of a tear in the intima, and it will dissect the aorta upwards, downwards. And we use the renal arteries as the defining structure between an abdominal aortic aneurysm and a thoracic aneurysm. And we'll talk about thoracic dissections and in a minute, but right now we're looking at Joe, who has an aneurysm. So all 3 layers of his aorta, and it's his abdominal aorta. So he goes to the OR. Here is kind of a picture of a normal aorta. Here is one that has an aneurysm, and here is one that has ruptured. The majority of patients do not survive a ruptured aneurysm. Joe was lucky. He arrested in hospital and he had a very astute team leader who said, hey, this is likely hypovolemia. Why would he be hypovolemic? And got diagnosed very quickly. So we went to the OR and had surgical intervention. So he had an abdominal aortic bifemoral bypass graft placed. And so when we talk about, there's a couple of videos here that you can watch. Joe went to the OR for an open repair. We often take healthy, well patients for elective, open repairs. And sometimes we save the endovascular or the less invasive procedure for patients who have more comorbidity. So you're welcome to look at those 2 videos that kind of help you explain. I quite like this video here. You'll enjoy it. It just watches an endovascular graft being placed. These grafts have come a long, long way in 20 years. We've been doing the abdominal ones for probably 25 years now. And the thoracic ones, we've just started doing them the past 5 years at the New Brunswick Heart Center, but they've been doing them across Canada and the US for a number of years. So poor Joe returns to the surgical ICU post-operatively. He's had 10 units of packed red cells in the OR. He's had 2 liters of plasma because he's developed a coagulopathy related to all of those blood products. He's had 16 liters of saline and lactated ringers in the OR. He is mechanically ventilated and quite hypotensive. We manage him for the next 9 days, and sad to say that he had his life support removed and he passed away. So unfortunate, ruptured abdominal aortic aneurysm. If these patients survive, they often have multiple complications. That's often related to the amount of volume and blood products that we have to give them. So unfortunate. Okay, so our last case that we'll look at today is a 33-year-old male, Mr. Gray, Mr. Goose, I guess is his name. He complains to his wife and he says, I got this really weird pain in my chest. His wife is a cardiac nurse and she kind of rolls her eyes and says, oh, honey, you probably pulled a muscle. And she goes about her evening routine. An hour later, Mr. Gray is still complaining of pain. And now he's not looking as great as he had been. He's a little diaphoretic and his color is a little gray. So his wife decides that he needs to go to the emergency department. So off they go. Here is his ECG that is really non-diagnostic. He's a 33-year-old man, might have some early repolarization changes in V2 and V3, but it's non-diagnostic. There's nothing exciting about it. And so they sent some cardiac enzymes and his troponin came back negative. And so they were pretty much ready to pack up. The emergency room physician said, you probably have pulled an intracostal muscle. Costochondritis is his working diagnosis. But his wife is looking at him and she's starting to feel a little bit uneasy. And she knows the emergency room physician and she says to him, could you just appease me? Because he described his pain earlier as a ripping or tearing pain, and he just told me this now. So the physician says, oh, sir, you should have told us when you came in that you had a ripping or a tearing pain in your chest. So the physician queries, oh no, I wish I had have known this when he first came in, because I would have ordered a CT as soon as he got here after his 12 lead was done. So that ripping, tearing pain is a very classic of a thoracic dissection. And so our patient goes over for a CT and he is diagnosed as a type A aortic dissection. So there's two kind of classification scales that you can use. You can use the Stanford or the DeBakey. We at the New Brunswick Heart Center use the Stanford. So type A is the ascending aorta up here. It can be from the aortic root up, and it can include the arch vessels. And then a type B dissection is the descending aorta. And so the alarming thing for Mr. Goose, and he is a true patient that we had, sorry, just a sec. Excuse me. So the emergency room physician comes over. The emergency room physician has almost no blood left in his face. He is pale, and he says to the nurse, who is Mr. Goose's husband, he says, oh my God, this guy is the biggest dissection I have ever seen. It starts in his ascending aorta. It comes down his descending aorta. It comes down his abdominal aorta. And it has dissected all the way down to his right popliteal. And so the nurse tries to maintain her composure, but she knows that the cardiac surgeon is on his way in. And so type A dissections are managed surgically, and type B dissections are often managed medically or with something called a TVAR, which is a thoracic endovascular graft. But type A patients will do so much better if you take them to the OR. And so Mr. Goose went to the OR, and 16 hours later, he comes back to the intensive care unit. And so here are just some pictures. Remember that you may have to reimplant the arch vessels. And it may even dissect down here into the coronaries. We really hope it doesn't, but sometimes the aortic root gets dilated and the aortic valve has to be replaced. Remember, the coronaries sit above that valve. So if you're replacing the aortic valve, you have to reimplant the coronaries because they are part of the graft. Sometimes we will call that a Bentall procedure. And so this guy had a graft all the way down. They even did his femoral and his popliteal. And he actually did really well. Thank goodness he was 33 years old. But does Mr. Goose have reason to have post-op pain? My goodness, he had a sternotomy, he had a thoracotomy, and he had a large abdominal incision. He also had a groin incision and a right leg incision. So yeah, this guy had a huge reason to have a lot of pain. He did really well, went home, and that was many years ago. He is still alive, fully functioning, and nobody really knows why he had that dissection. He was investigated for different connective tissue disorders, and nothing has come back genetic wise. So it's kind of a strange happening, but a very lucky man. And that is the end of our discussion about vascular.